Okay. Yeah. Okay. So, all right. So we're going to be talking about hematopoietic function, and what that's referring to is your blood, right? So what we're going to be talking about here mostly is, what we're going to be talking about here is the development of the blood cells. Hopefully, y'all saw the hand. Did y'all see the handout online? I was supposed to give that a read before you study, or if you haven't already. But what we're going to be looking at mostly is white blood cells disorders, uh, where we're going to be looking at mononucleosis, leukemia, lymphomas, and multiple myelomas. And we'll also take a brief look at red blood cells, looking at anemias and thalassemia, uh, and then hemostasis and looking at clotting diseases briefly. We're going to be going over those more, though, at the end of the semester. I guess I should have probably done it differently, but whatever. We'll eventually get there. Talking about your blood today, right? So this is 8% of your body weight is blood. So the rest of it is mostly just cellular mass and the water within cells. But only about 45% of your blood, of the liquid part of your blood, is actually blood cells, which is white blood cells and red blood cells. If you take blood that you drew from someone and then spin it down in a centrifuge, what you realize is that most of it's just liquid in and of itself. It's the fluid component of blood, which is plasma. Plasma can be sub-centrifuged even more into different amounts of proteins. These are proteins like your complement system, different factors, that things like albumin that help mobilize fats around your body. There's just a whole bunch of proteins just free floating in your blood. But most of it's water, obviously, and then there's other solutes, things like salts and different chemicals like, I don't know, there's a whole bunch of examples there. Here you go. Things like ions, nutrients, waste products, gases, carbonate is a great example. Albumins, globulins. So that's like your immunoglobulins, your IgGs, your antibodies, and then fibrinogens like a connective component. Now, if you centrifuge more the formed elements, which are just your solids in your blood that's not dissolved in water, what you'll recognize is that most of them are red blood cells, erythrocytes, but about a small portion of them are leukocytes, meaning your white blood cells, and a portion of them are platelets. And these are all just your different percentages of all your immune cells in your blood. Now, this does not include all of the immune cells associated with your lymphatic system, which are your lymph nodes right in your neck. That's where most of your lymphocytes are. Your T cells and B cells and antigen-presenting cells, they're all in your lymphocytes. So this isn't the percentage of immune cells in your body, but it is the percentage of immune cells in your blood. When we talk about disorders of the immune system, what happens is that anytime you have problems with these cells, what you've done is you're going to lose the function of those cells. So we're going to talk a lot about if you have either too much of a cell or too little of a cell, what that does to your overall blood composition and the actual function of that cell type as well. A lot of it's super intuitive once it's just told to you, though. So we have the different development stages. So we have the pluripotent cell. This means that it can give rise to multiple different cell types, and it's a powerful stem cell that gives rise to two major different cell types: your common lymphoid progenitor, your CLP, and your common myeloid progenitor, which is your CMP. Now, your common lymphoid progenitor, that gives rise to all your lymphocytes, and there are three different types of lymphocytes: your NK cells, your T cells, and your B cells. Right? That's important for the testing purposes. But then you also have your common myeloid progenitor cells, which gives rise to monocytes and granulocytes. Your monocytes gives rise to macrophages eventually. Doesn't look like that's on here, but a lot of times this graph will have another arrow that says macrophage underneath monocytes. But whatever, just your monocytes. And then also your granulocytes, which the granulocyte classification are your eosinophils, your neutrophils, and your basophils, which we'll talk briefly about today. And then there's this other ones which give rise to your red blood cells and your platelets, but those also come from the common myeloid progenitor cells. So make sure you just know which different cell type is associated with which lymphoid progenitor cell. All right. So when we talk about the different cell types, we have neutrophils, eosinophils, and basophils. These have different functions for your immune system. You have neutrophils; those are the first thing to really be recruited to the spot of infection, and they are a major part of the immune system, about 60 to 65% of your total white blood cells, and they're really powerful because they can phagocytize things and they can release granules. Because they are a granulocyte, they can release granules which contain a whole bunch of pro-inflammatory molecules within the granules. So all of these are really pro-inflammatory cells that release chemicals out into the environment, right? So your neutrophils can also do phagocytosis, though, which makes them a really powerful cell, and that's why they're the first to be recruited to initial sites of infection. Eosinophils are really important for dealing with parasites. So when we talk about the whole hygiene hypothesis that we were talking about earlier, these are the actual specific cell types that we're referring to, that eosinophils need to be exposed to certain levels of parasites, and then if they're not, they will respond to other allergic responses. So they're a major thing in allergic responses and help fighting parasites, right? So these are what responds to like pollen and peanut allergies whenever they get activated. And there's basophils. Admittedly, I don't know as much about basophils, but they're just involved generally in inflammatory reactions with allergies and other inflammatory mediators. All these names come from the fact of how all three of these names come from the fact that how they absorb dyes. So neutrophils. So what people do is they expose these cells to acidic and basic dyes. So neutrophils don't absorb either one of them, so they are neutral. So they call it a neutrophil. A eosinophil, the acidic dye is called eosin, and so if it absorbs eosin, it is an eosinophil. And the basic dye is, I don't know what the name is, but it's a basic dye, and so they just call it basophil, right? So because it absorbs the basic dyes. So, and then these things come out in different colors depending on those dyes, right? So eosin is a red one, and this basic dye is a blue dye. So it's all that's how they get all these names from. So we also have lymphocytes. So this is your B cells, your T cells, and your natural killer cells. They all come from the common myeloid progenitor, and this is what we were talking about last slide. Whenever you have just the development of your T cell receptor and your B cell receptor, which gives rise to your antibodies. That's all your lymphocytes. Natural killer cells are also part of that. Natural killer cells are a cell type that's very, very similar to helper T cells. They're just not part. They're just part of the innate system, though, and generally respond to pathogenic patterns rather than specific targeted antigens of the adaptive, like T cells do. And then we also have your monocytes. So monocytes have this really big curved kidney bean shaped nucleus. That's how you identify them. You identify lymphocytes because most of the cells actually have nucleus, because they're developing different proteins from that. With monocytes, it's a very, very large cell kidney bean nucleus, and what's important about them is they are antigen presenting cells. They are very good at phagocytosis, developing the antigen and then presenting it to the adaptive arm for development of T cell and B cell responses. And then macrophages are also really good at doing that same thing, and that is because macrophages come from monocyte lines, and both these things come from the common myeloid progenitor, which you saw in the last slide. So the first concept we're going to talk about with hematopoetic disorders is leukocytosis. So what this means is that the cytosis suffix means that you have like a lot or too many of whatever the thing is. So if you have leukocytosis, you have too many white blood cells, right? Because leuko means white in Greek, I think. Yeah. So leuko, and that's where we get leukocyte from, is a white cell, right? So we have, so if you have increased numbers of white blood cells, this is what leukocytosis is. And it's particularly evident in the bone marrow. Spill over to the bloodstream, and you lead to abnormal function. You have just too many white blood cells that are responding too much, and you're getting too much inflammatory responses. The suffix philia also means increased numbers as well, and so if we have something like neutrophilia, what you're referring to is just an increased number of whatever that prefix is, where if it's neutrophilia, it's increased number of neutrophils. So be able to recognize the suffixes and prefixes and know what each one is referring to. Now, this contrasts, so leukocytosis contrasts to leukopenia, where you have a decrease in the absolute number of cells, specifically leukocytes. And so, obviously, if you have less white blood cells in your bloodstream, you have a decreased ability to respond to infection. And so this happens particularly with things like cancer cells. If you have we'll see this later, I think, but if you have like a cancer cell that affects monocytes, for example, what happens is that all your resources go into developing your monocytes, and so all the other immune cells get crowded out, kind of. And so you have a generalized leukopenia for everything except for your monocytes, right? And then this also, a really great example is HIV infections. Again, a virus that comes in and targets that CD4 positive T cell. Obviously, you're not going to have any CD4 positive T cells because they're killed directly. And then the things that are activated by CD4 T cells downstream, which are the B cells and the cytotoxic T cells, those also have decreased numbers as well, to where you have a general decrease in overall white blood cells because of an HIV infection. Okay, yeah. So this is what I'm saying with the kind of relationship of these things. So what'll happen is that if you have some type of, I gave the example last slide, which is the opposite of this, but the same is true for the flip, where if you have some type of cancerous white blood cell, what happens is all the resources will go into that, like if it's a B cell lymphoma or something like that, everything will get developed and shuttled into that, and so you'll have decrease in other different cell types, and that's what this crowding effect is. I think y'all kind of understand that. So another we're going to be talking about a lot of like blood cancers today, but this is like the one non-cancer condition that is prevalent. So this is mononucleosis. So a lot of people have heard about it at this point, but this is the kissing disease more commonly in adolescents and young adults for two reasons. One, obviously, that's like they're like going around just making out with everyone, right? But the second reason is because this is caused by a virus. Specifically, 99% are all caused by just two viruses. The major one, which is Epstein-Barr virus, EBV, causes like 90% of even that, right? So, 96%. Another 6% is caused by the virus I study again, which is cytomegalovirus. And the thing, both of these are in the same class of viruses called herpes viruses. And what happens is that these get transmitted through secretions, and mostly through secretions of the salivary glands. But it also can go through like breast milk and other secretory mechanisms. But the thing is that because before adolescence, right, when you're like an infant, when you're a child, like up until you're like 12 or whatever, you don't get exposure to salivary glands because you're not kissing anyone, right? And so it's just when that activity starts is when you get exposure to this, and this is when you get infected with this virus. So it's just caused by a virus through and through. Symptoms occur about 4 to 8 weeks after infection. You get fever, sore throat, atypical lymphocytes. And its serious complications can come where you have splenic rupture, and it can even cause death, but it's very rare and in places with good health care. And the treatments are just going to be, it's a virus, so there's not really great treatments. We do have antivirals, but people don't typically deploy them just for something like infectious mononucleosis unless it gets really bad. But so mostly it's just bed rest, over-the-counter anesthetics, and it'll just resolve itself. Again, what's happening is, like I was mentioning with HCMV, same is true for EBV. These viruses, herpes viruses, they come in, they replicate really, really fast, and then your immune system develops really robust responses to them to where they are quelled, and they just live inside of you latent for the rest of your life. and it's not until you become immunocompromised where they can really flare up and cause really problems. So this is just that initial flare up, that initial infection is where you get that mononucleosis responses. Does that make sense? Good. So yeah, a lot of it, again, like I said, is leukemias where we're going to be talking about moving forward. And this is cancer of blood forming cells, leading to uncontrolled production of abnormal white blood cells, which overtakes production of normal white blood cells. So what we're getting at here is that all the stuff that we talked about, she just left. She's disappeared from me. So all the stuff we talked about with cancers are specifically still applicable to leukemias, right? Because this is just a cancer of the white blood cells. So all the stuff that we talked about with like cancers of progenitor cells are more malignant than cancers of differentiated cells. We mentioned like that concept. All the mutations that occur, all of that whole lecture is directly applicable to the leukemias, obviously, because this is just a subsequent cancer. But this we're talking about today is more classification about what's going on with regard to the what specific cell type is getting cancerous and if it's acute or chronic. So we have this like kind of development, this 4-quadrant system, right, where it's like you have acute cancers and you have chronic cancers and you have different cell types, whether you're myeloid or whether you're lymphoid. So if you're lymphoid, so you can have all the 4 different combinations of those 2 classification systems. So with acute cancers, obviously they develop really at earlier stages, and then they're immature non-functional cells like blasts, and they grow very, very fast. That's what really is the hallmark of acute cancers. They're very aggressive with short life expectancy, weeks to months, rather than something like chronic, which will give you like years of survival, right? Chronic develops from more. So these acute cancers, it's more of a progenitor that gets the cancer. With the chronic cancers, it's later stages of blood cell development, generally speaking, and so it's more mature cells, and it's slower growing. And what people typically do is they wait to make sure there's cancers, and then start treating accordingly, depending on where things are. And these chronic cancers, just like anaplastic cancers that we talked about in the cancer lecture, they can revert back to a previous stage, and they can develop into acute leukemias. So that's an important complication to monitor as healthcare providers as well. So with regard to the 4 different classifications, we have acute lymphoid leukemia. It's very fast growing. There's a lot of blasts in the blood, failure to mature and release blood, and it's most common in children. So acute lymphoid leukemia is ALL. Chronic lymphoid leukemia is a more slow growing because it's chronic. There's no blasts in the blood, but it's production of more yet dysfunctional lymphocytes. Again, whatever the cell type that gets affected by these cancers are going to be whatever those functions are going to be dysregulated. And it's more commonly in elderly. These are cancers that develop from things like loss of telomeres and stuff like that, right? So then there's also acute myeloid leukemia. It's fast growing, a lot of blasts in the blood. But there's also chronic myeloid leukemia. It's other than so it's cancerous white blood cells other than lymphocytes. So right, like neutrophils and myeloid cell types. So it's not lymphoid. So neutrophils are the most common. Slow growing, obviously, because it's chronic. So a lot of these things is you can just recognize the rules of the difference between chronic and acute, and then recognize what type of cell is in the classification, and then you can usually piece together pieces and parts and then put together what type of cancer it is. So a good test question would be like, oh, this person has a really aggressive like form of cancer of T cells. What type of thing is this? And you have to know that T cells are a lymphoid cell type, so it's a lymphoid cancer, and then if it's really aggressive, it's acute, so it's acute lymphoid leukemia. Does that make sense? All right. So these blast cells, we kind of mentioned these a couple times, and what these in the past slides, right? What these are, they are immature cells that give rise to differentiated specialized cells. So it's these progenitors, right? So all of this upper line right here, those are all blasts. and then they develop into things like NK cells, monocytes, blah blah blah. Right. And so if you have a loss of these cell types, what happens is it also affects whatever the downstream, which makes a lot of sense, right? So if you have the like a lymphoblast, if you have a problem with your lymphoblast, right, everything downstream of your lymphoblasts are going to be affected, right? Um, same with monocytes and also your myeloblasts as well. Right. So yeah, if you have a problem with your monoblasts, it's going to affect your monocytes, which will also affect your macrophages, and same with your lymphoblasts and your granulocytes. Forgot I animated that. All right. So signs and symptoms of leukemia, what you're looking for is fatigue. This is just like your cancers, right? A lot of the stuff that's applicable from your cancer lectures or neoplasia lectures also here, where you have fatigue and muscle weakness, you lose a ton of weight, you got fever, night sweats, and these little purple patches on your skin that you can see in the picture here on this guy's skull. And then you're very susceptible to infection because another thing with these leukemias is that they're kind of only focused on, like, you'd think, oh, you have a leukemia, you're not going to get any infections because you got a whole bunch of white blood cells around. The problem is that these white blood cells, they're like almost solely focused on dividing and aberrantly replicating. And that's what a cancer is, right? To where they're not really responding to infections very well. So you do get an increased amount of infections. And then there's also the crowding out effect that we talked about as well, where if you have like a monocyte line that goes down, well, that'll be really good for extracellular infections, but you can get a whole bunch of intracellular infections because the monocyte cancer is crowding out T cell responses and natural killer cell responses, which are both the cell-mediated arm of the immune system, meaning you're not responding to intracellular pathogens as well, right? So you have a higher susceptibility to viral infections. You also have an enlarged spleen, bleeding from the gums, and then there's like there can be these gum hypertrophy as well, where you just have your gums start growing a lot. And then bone and joint pain because you have more blood going through your capillaries than should be. So as far as treatment goes, we have chemotherapy, radiation, immunotherapy. Again, a lot of the cancer stuff applies here. There are targeted therapies about Gleevec, which I think we talk about later, so more on that later. Bone marrow stem cell transplants, because what you can do is you can come in and then eliminate all white blood cells. There's like a way to do that. And then what you just have to do is come in and then replace the white blood cells with non-cancerous white blood cells, and then from a donor, and then you can fix it that way. There's also gene therapy targeting certain cancer cells, certain genetic components of cancer cells, and but it really depends on the type of leukemia, the stage, and severity, of course. You want to tailor make your treatment based off of whatever the patient's signs and symptoms are, right? Admittedly, though, there are not really good therapies for chronic forms of leukemia. Patients is monitored to determine if the progression leads to acute, but it's very hard to treat people at that stage. Okay, yeah, so there's this Philadelphia, so yeah, this is what I was talking about with Gleevec. So there's this concept in chronic myeloid leukemias where there's the existence of a Philadelphia chromosome. So what happens is, it's kind of weird. A chunk of your chromosome 22 and your chromosome 9 will fuse together, and you'll have an additional chromosome that has these two little chunks specifically within the cancer cell. And so it breaks the end of 9 and 22, and then they kind of like fuse together. And so what researchers have developed, Peter Nowell and David Hungerford, developed this drug, and what it does is it targets the BCR-ABL and fusion protein. So what happens is that these proteins from different chromosomes, they fuse together. Well, naturally on healthy cells, they're separate, full through and through. So if you can develop a therapy that targets that fusion, it's not going to affect any of the healthy, normal cells, but all the cancer cells that have this Philadelphia chromosome that have fused these genes together, they will absolutely be affected because that's the only place that it exists. And so so this Gleevec, you might talk about it in pharmacology, I don't know, but it's proven to be really, really effective against this Philadelphia chromosome and treating these CML patients. Does that make sense? All right, cool. So we talked about all the white blood cell diseases, and so now we're going to move on to lymphomas, which is after leukemias here, right? So with lymphomas, do y'all know about the lymphatic system? Y'all taking anatomy, right? Through and through. Okay. I didn't learn about the lymphatic system until I got to like immunology, like as like a junior in college. Like it was weird. I just missed it in everything up until that point. I thought it was like this like hidden secret or something, but I don't know. But it's like the true organs of the immune system, I guess, is the best way to put it, right? To where you have all these little lymph nodes that are all over your body, right? Well, if those lymph nodes and the cells that are contained within those are all your lymphocytes, which are your B cells and T cells mostly, and some other cells as well. If those become cancerous, you have growth of these massive bulges at your lymph nodes, and so these are your solid tumors of your blood cells, if that makes sense. So yeah, malignant transformed lymphocytes and lymphocyte precursors, bulky, painless tumors at your lymph nodes. And there's two major categories. There's Hodgkin's lymphomas and non-Hodgkin's lymphomas. So right, these are all lymphomas rather than leukemias. Leukemias are more like your liquid component. Lymphomas are more your solid component. So make sure you make those. Now symptoms include tumors, fever, night sweats, and then weight loss. Right, all the things associated with cancers already. And then you just want to actively surveillance. What's great about this is you can do not only can you do bone marrow transplantation and chemotherapy like before, you can also do radiation therapy and target that specific site of wherever that lymph node is that is cancerous, right? So we're going to be talking about the two different types, Hodgkin's lymphomas and non-Hodgkin's lymphomas. Hodgkin's lymphomas are characterized by the presence of Reed-Sternberg cells in the lymph nodes. And so this is what you got to do is you got to go in and take cells from the patient and do the microscopy work to figure out there's Reed-Sternberg cells in the lymph nodes. But once you do that, what these Reed-Sternberg cells are is they're this really, really weird looking lymphocyte. So you can see here pictures of lymphocytes, right? We saw that in the previous slide looking at different cell types. Lymphocytes are very, very compact, but 90% of them is just nucleus, right? Where it's like mostly nuclei. With these Reed-Sternberg cells is that these have multiple nuclei and then they just look fundamentally different than these normal lymphocytes. And so that's how you can really do it. Now, clinically, you'll see a whole bunch of upper body tumors. By upper body, we just mean above the waist mostly. But you can see here, this is a tumor at the neck. Right? There's a whole bunch of lymph nodes in your neck. That's what doctors probe whenever you go in for if you have a viral infection. There's a lot of viruses that cause inflamed lymph nodes in your neck. But this is a cancer of that neck here, of those lymph nodes in your neck here with your Hodgkin's lymphomas. And again, typical symptoms: fever, weight loss, night sweats, pruritus, which is just being itchy. So it's large and multiple nuclei in your Reed-Sternberg cells. So that contrasts to non-Hodgkin's lymphomas, which is just a generic term for all the other non-Hodgkin's lymphomas, right? It's like so it's just everything else. It's not Hodgkin's lymphoma, where you have a whole bunch of lymphomas, but there's no Reed-Sternberg cells. and then these tumors can be all over the body. So be careful here on like tests where it's like just because you have a cancer at your neck, for example, that doesn't tell you in and of itself that there is a Hodgkin's lymphoma, because non-Hodgkin's lymphomas can also be all over your body, right? Just you won't see Hodgkin's lymphomas in your legs and your lymph node legs, right? Tumors all over the body, found in all ages, linked to chromosome translocations. There's EBV, which is what we talked about with mononucleosis. That is that's associated with lymphomas, bacterial infections, a whole bunch of other stuff. What you have is clonal expansion of B cells. Do y'all know what clonal, what clonality is in immunology? If y'all heard that term. So, right, if you get infected, right, your body will start developing cells that target one specific little spot on the antigen. Let's pretend it's COVID, right? It's like that spike antigen, one specific spike on that spike antigen of COVID. A whole cell is just dedicated to fighting that one spot. The thing is that there's a whole bunch of spots all along everything on that virus, right? To where if you're a cell type that is really, really good at fighting COVID because you're fighting this one little spot on the spike, that's just one cell that's doing it. Your body wants a whole bunch of copies of that one cell type. That one cell is called a clone. And so if you have clonal expansion, it's like a good immune cell to have, so that one specific cell type will start to really divide, and you'll have a whole bunch of different copies, and you'll expand whatever that clone is. So you have clonal expansion of B cells. What we're really referring to is that there's just one cell that's that's cancerous, and it's a B cell, so it's like that clone keeps expanding, and what'll happen sometimes is that you get a whole bunch of antibodies produced against whatever that random mutation that is clonal. Whatever that antibody is producing can have like problems with that, but we won't really go into all of that. It can also happen with T cells or NK cells, any of your lymphocytes, right? Again, just like we said, we have changes in proto-oncogenes and mutations against tumor suppressor genes. This is just like what's good about this lecture is that it's a whole bunch of, it's like an overlap of your immunity lecture and your cancer lecture, right? So where it's like you got to study it, but it's not like fundamentally earth-shaking here. You just got to study details like this rather than like really understand a fundamental concept. So another lymphoma is your Burkitt's lymphoma. It's the most common type of non-Hodgkin's lymphoma, so it's a subcategory there, and it's very fast growing. And specifically, this picture is really shitty. I don't know. I feel like we can get a better. I should have gotten a better picture, but you can see. I think you can see pretty well, maybe more easily on your computers. Like it's like of his jawline, right? So, and it's because that's where most of your tumors are going to happen with this. It's around your face and your jaw, and associated with EBV, Epstein-Barr virus, nasopharyngeal secretions. Your nasopharyngeal epithelia is like kind of in the back of your throat, in between your nose and your throat. That's where a lot of the herpes viruses initially infect, and that's why like mononucleosis causes like a sore throat. That's why it's infecting specifically your nasopharyngeal epithelia. But yeah, we have certain antibody treatments. Ruxolitinib, y'all know like terminology. Have you learned this in pharm yet, or just life?
We only have one class.
Really? Yeah. So if a drug ends in mAb, what that stands for is monoclonal antibody. And now, so it's saying it's an antibody that came from one, right? We know what clonality is, right? So it's one clone of antibody. It's an antibody that we're isolating. That's all produced from one clone, and so it's a monoclonal antibody. And so they tack that at the end of drug names to say what type of drug it is. So this isn't some like random chemical or whatever. This is an antibody that gets injected into people's veins. You can't take it through the mouth, right? Because of your stomach acid. It gets injected through the veins, and then it's like a therapy. There's like a whole bunch of antibody therapies that you'll probably learn about in pharmacology. But this is so you're giving a certain antibody to these patients And what that's doing is it's activating the innate arm to attack cancers to attack this specific cancer, this Burkitt's lymphoma, rather than relying on your immune system to attack it. And then there's also chemotherapy, obviously, other chemicals that aren't antibodies that can help fight it. There's also multiple myeloma. Multiple myeloma is like scary, dude. So I guess all cancers are scary to a certain degree. So these are malignancies of plasma B cells and bone marrow, more common in men than women, and also more common in African Caribbean descents.
Oh,
Now, wait, what?
No.
Okay. So people typically get this when they are old, admittedly. But what you get is this production of this thing called an M proteins. Also called the Bence-Jones protein, but I don't know. I've never heard anyone call it that. I just see M protein. And what this is it's a protein that antibodies will start to be developed against. But so what these M proteins are themselves, they are antibodies, but they don't have a target to really anything of note. It doesn't attack anything in your body or anything foreign. So it's like people are just very puzzled about what this M protein is really like. Why? Because antibodies don't get developed unless they target something, and so it's like very strange that this doesn't really target anything in your body or foreign. So it's like, what is it targeting? Why is it being developed? It's very confusing to immunologists. But y'all don't need to know that, obviously. Y'all just need to know that it just doesn't have a main target. And so So you normally have plasma cells that get generated with these multiple myeloma cells. They are abnormal plasma cells that live inside that are in your bones, and they secrete mediators that stimulate osteoclast, resulting in bone loss or skeletal pain. So it can affect like your bones when you have these multiple myelomas. So as far as clinically speaking, you have increased osteoclastic bone destruction, right? Because it's targeting these bones. You get like very weak bones, effectively, at the end of the day. And so the best way to remember the signs of multiple myelomas is an acronym CRAB, which is you have elevated calcium levels, you have renal insufficiency. What happens is that M protein gets filtered by your kidney, but so much is being produced that it like clogs up your kidney, and so you have problems with your kidneys. You have anemia, right? Because your blood's messed up, and you have bone lesions because you're attacking your osteoblasts. So drugs that can treat multiple myeloma is thalidomide or Revlimid. I'm starting to question whether or not I should ask like drug questions, because you'll get this in like pharm. I don't know.
Like not right now. I don't think it would be fair because we have pharmacology on these days and we only have like one lecture.
Yeah, and I don't want y'all to like get like bogged down and confused with drugs. So I may take those questions off. I think currently right now the test has a couple questions about drugs, but I might change that. Yeah, let's just go ahead and make that a rule for the course. I don't think there's ever really an instance where you need to learn the drugs. So we'll just go ahead and simplify that for y'all. If you see drugs that are bolded, forget them. I'll eliminate those from the test. Fair enough? Because this is not a pharmacology class. You're supposed to learn the underlying diseases rather than the drugs to treat them. So don't even worry about Gleevec. Remember earlier? Just understand like the concept of Philadelphia chromosomes. Fair enough? All right, where are we at? All right, so yeah, the problem with this lecture is also there's a whole bunch of words that sound very, very similar. And it's all rooted in lymph and Luke. mostly, and then all the suffixes associated with it. So just know that Luke means white, lymph means your lymphoid organs. If you know like the background about what if you're just trying to memorize the words, it becomes a lot. But if you really recognize these prefixes and suffixes, it becomes a lot easier in what they mean. Um, so yeah, just make sure you get all the terminology right. We don't want to miss questions because of like misreading questions and thinking it said one thing over another. All right, so next we're going to talk about these red blood cells, right? That's just a separate arm of the development. Erythrocytes, or reticulocytes, and then, sorry, erythro, eryth, erythrocytes, erythrocytes. Yeah, I don't know. There's supposed to be different words, I think. I think it's mislabeled in the picture. Regardless, I need to know that. Just know that these are the developmental stage. It eventually leads to an erythrocyte, which is a red blood cell. It's coming from the common myeloid progenitor cell line as well. So erythrocytes are the big thing with them, right? Effectively, what they are, they come from a cell type, a precursor. This reticulocyte. Reticulocytes are great because they've got nucleus in all the components. Whenever they differentiate into erythrocytes, they lose the nucleus. So you have this like little dip in the blood cell that you can see microscopically. And that's because there's no structural, like there's no nucleus there. It's really interesting that red blood cells they're not actually cells. They're just like, they're a membrane bound little pocket that has the ability to live a couple days, but effectively all they do, their main function is to just have hemoglobin and transport hemoglobin around the body and transport oxygen bound hemoglobin or carbonate bound hemoglobin around the body. So have y'all taken biochemistry? Have all y'all taken biochemistry? You haven't? You have? Does everyone else? No? Okay, yeah. In biochemistry, this is like their thing, right? We spend like 2 weeks on just hemoglobin and talking about all the little ins and outs of it. It's extremely complicated. But at the end of the day, what all hemoglobin is its ability to bind iron. It's a protein that stabilizes an iron molecule. I was a biochem major at LSU, so like I spent more time talking about I'm so tired of hemoglobin. The all hemoglobin is it's a protein that has iron in it, and that iron will come in and it'll bind oxygen, and it can also bind carbon dioxide as well. So what effectively what this does is that when there's high concentrations of oxygen, like there is in your lungs, hemoglobin will rush past your lungs. It'll bind that oxygen to that iron molecule. There are 4 different chains of it. There's 2 alpha chains and 2 beta chains. So there's 4 different spots for oxygen to bind. And oxygen will come in, bind to that hemoglobin in the lungs, and then the blood will travel throughout the body. Eventually it reaches the tissues. There's a whole bunch of things that cause oxygen to be released in the tissues. And then what's great is that these hemoglobin will also pick up carbon dioxide. And so that's great because that's the product of your respiration. Because of the Krebs cycle, there's a whole bunch of releases of carbon dioxide, and then there's high concentrations of carbon dioxide in your tissues and low concentrations of oxygen. So there's like a switch on hemoglobin. And this is how your body oxygenates your tissues and then removes the carbon dioxide. And so you breathe in oxygen, and then your red blood cells will travel back up to your lungs, and you'll breathe out carbon dioxide, right? Yeah, I think that's mostly what we're saying here. So yeah. Importantly, though, there's these 2 alpha chains and 2 beta chains that'll be important for later. And then, so yeah, iron's a really important component, but also the development of the actual development of the reticulocytes into the erythrocytes. You need other vitamins like vitamin B12 for DNA synthesis and folate. DNA synthesis. It's really the nucleotide synthesis, which is a part of DNA, I guess technically. But yeah, we'll talk more about folate and these single carbon donor molecules when we talk about pregnancy. This is like single carbon donors are really, really important for baby development, and that's why you take folate whenever ladies are pregnant. They take like a lot of. I don't know. Does anyone ever have kids? You have kids? Yeah. So you're probably told whenever you're pregnant to like take a folate vitamin or eat foods with a lot of it. Yeah, there's a whole bunch of it can get there too. There's a lot of sources of it now. It used to be a major problem that like just straight miscarriages would happen, but better healthcare led to better less.
No, it's different.
So anytime in chemistry that you see like a word and then ic acid, what that means is there's a negative charge on that molecule and there's a hydrogen attached to that, right? So you see in sulfuric acid, folic acid, whatever. If that hydrogen comes off that's an ionized version of that molecule now, and that's when you see 8. So it's the same molecule, but it's just whether or not it's protonated or not. And so you can replace that hydrogen if you want to remove the acidity of the thing. You can replace it with a salt, something like sodium, and then you can have the salt version, and it's like pretty much pure folate. And so if it's the salt version, you'll see folate on the thing because they're fully soluble. But if it's the hydrogenated version, but it's the same stuff. Like in your body, it just exists as the anionic form. So it's all, yeah.
Potential of hydrogen, right?
Yeah.
Mm-hmm. And acidic stuff has a lot of hydrogen.
So it's got lower pHs, yeah.
Right.
Mm-hmm. Because of the negative log.
Right.
Yeah. All right. So, all right. That's a side tangent, though. Timeline of erythropoiesis. So it takes a while to develop. So over the course, when you're an infant, most of your bones are actually have a huge amount of bone marrow in the bones. But by childhood, the stuff develops and goes away from just having so much compact bone marrow and goes into having yellow marrow, which is more. It loses your hematopoetic potential, and that's why as over you age, you just don't need as much development because you're not growing and you're not trying to like supply as much growth, and metabolically you don't need it. But the problem is, by the time you're an adult, you lose a lot of that potential, and you just have a small amount of your bone percentage is actually hematopoietic, has a high amount of hematopoietic potential. Now you always need that because red blood cells don't live very long, so you need to constantly be making red blood cells. And they don't live that long because they don't have the ability to go through transcription, right? Because they don't have DNA.
Can't you eat like animal bone marrow?
Yeah, for sure. But importantly, what you're doing there is you're just it's going through your stomach acid, right? So all proteins and all live cells are going to be reduced down to their peptide, to their primary structure peptide sequence level. And even further, peptidases will come off and they'll just be reduced down to the amino acid level. So it's like, yeah, you can eat it all you want. A lot of nutrition's there, everything you need, and that's why people eat it for like health benefit wise, is that everything you need is like there, right? For all growth. Because these cells are very nutrient packed, but like you can't, like it's not gonna translate into like having reproductive, like hematopoietic potential.
What do you think about eating placenta?
Again, it's a nutrient packed source of food. I'm gonna stick with hot dogs myself, but it's like I mean, you can eat whatever you want, I guess, because eventually it's all gonna be reduced down to its micromolecular level, and it's got a lot of potential because it was supporting the growth of a baby. But and I mean, people are doing studies on it to see like how much health benefit it gives to like.
Stem cells and stuff. Like I would like to do that. It's super beneficial.
Yeah, so I mean, people do studies about it. I haven't read all the studies, but I've read like reviews and stuff, and it's like people say it has impacts. So that's just a decision that everyone needs to make with their doctors, Yeah. And if you're down for it, you're down for it. I don't want to yuck anyone's yum, All right, so, all right, so yeah, what's going on here is that you have normal oxygen blood levels. If your body is getting perfect perfusion of oxygen to the tissues, you're good to go, right? The problem is that if certain cells die, or if like you get in a car wreck, lose a whole bunch of blood, you donate blood, even like anytime you have a mass amount of loss of blood, but the problem is your oxygen won't be delivered properly to your That's why to your tissues. That's why they say don't work out after you donate blood, right? Or climb up stairs and stuff like that. It's because like you just don't have that oxygen carrying capacity. So what that does though is that those reduced oxygen levels will stimulate the release of a protein called erythropoietin. And what this does is it stimulates these erythrocytes, which are the precursor. Sorry, the reticulocytes. It stimulates these reticulocytes to divide into erythrocytes. This erythropoietin. And so what that's going to do, obviously, is that if you're stimulating that development from reticulocytes to erythrocytes, then it's going to make more red blood cells, and that's going to eventually lead to increased capacity. So this is the negative feedback loop that leads to proper maintenance of red blood cells, right? To where you're going to keep creating red blood cells until the oxygen capacity is restored to normal. And obviously, you might have heard of the what's that dude's name? Lance Armstrong. He did that blood doping, and what you do there is that you take out your red blood cells. Your body will go through this process, make more red blood cells, and then you inject those same red blood cells back in, and you've hyper increased your red blood cell oxygen carrying capacity, and so you can do a lot more working out.
You rode the bikes, right?
Yeah.
Oh yeah. Our last physiology professor was telling us about him.
Yeah, so yeah, that's what's going on there. Blood doping. He's like part of that, and there's like other people who do it, but it's like he's the token child.
Necessarily, not illegal, but
no, it's illegal and like yeah, you can't do that stuff. Also, like
he did get cited for that, right?
Yeah, I lost all of his
Okay.
medals and stuff. You can't ever go back.
Well, yeah, now he's old though. I mean, he made his money though. It's like who cares? Yeah, you can't do that in like biking or marathon athletes will do that too, and triathletes will do it. Like a lot of these distance ones. Oxygen is really helpful for distance stuff. I don't know if it really helps with like powerlifting and stuff like that, but okay. So we also have hemolysis. This is the destruction of red blood cells, and this is where you get things like jaundice, right? What happens is that these red blood cells have a limited lifespan, about 4 months ish, and they need to be constantly replaced. And what'll happen is these red blood cells they'll either die, and mostly the way that they die is they get squeezed to these capillary beds. These capillary beds you might have seen before in physiology that they're very, very narrow, only big enough for really one red blood cell, right? Well, with that shear stress that happens at that stage right there, there's a lot of destruction within the movement of capillary beds in that movement of red blood cells through the capillary beds. And so what will happen is you'll just pop that red blood cell and you release all of that hemoglobin into the blood. All right. Well, the first thing that happens is that the hemoglobin will start to get digested and processed. The thing is, it's in your blood, though, right? The first thing that it gets processed into is a molecule called bilirubin. And what's great about that is that so bilirubin is like this like yellowish color. And the thing is your liver can conjugate this bilirubin, and then this leads to the removal of bilirubin from the blood. This is like a mechanism that you want to make sure that there's not just hemoglobin all around your blood. You want to have a process to remove these proteins from your body, but specifically hemoglobin, because you can't just remove all proteins because you want your antibodies and everything else in there, right? So what'll happen is that if you have a problem with taking out the bilirubin from the blood, bilirubin in and of itself, it's changed from this red color to a yellow color. And so these people that have jaundice will have like the buildup of like yellow eyelids, eye whites, sclera. Yeah, that's what it's called. I've never taken an anatomy class. My anatomy's like garbage. I wanted to, but at LSU it's like a kinesiology course. It's not a biology course. Or it was when I was there. Regardless, I never had that opportunity. So yeah, you have like buildup of whites, and then also like your face will yellow where you normally have red blood flow. It'll like yellow over time. So the rate of destruction of your red blood cells, if that exceeds the rate of production, then you can get a buildup of jaundice. Okay. So we have all these. So the next few slides are different characteristics of how your red blood cells kind of function. So we have polycythemia, anemia, and okay, just two. I thought there was another one. Whatever. So we have polycythemia, cythemia, and what this is it's an elevated hematocrit. So again, when you spin down, this is important percentage wise for your test too. When you spin down, right, your whole blood, about 45% of it is, or about 55% of it is, no, 45, yeah, you have about 45% of it is red blood cells, right? Well, if the amount of red blood cells is excessive, what that leads to is a condition called polycythemia. So where you have an increased percentage of red blood cells in your hematocrit, right? And this could be due to a couple reasons. The first being you are severely dehydrated, right? So if you are really dehydrated, all of your the liquid component of your blood is going out into the tissues, and you're just depleting the fluids in your blood. And so it just, whenever you take, however much you need, it just looks like the percentages of water to red blood cells is off, in that you have less water, so it looks like you have more red blood cells. And so there are a couple different things that would cause that, dehydration being one of them. Also protein loss. We're going to be talking about this in the blood pressure stuff a little bit later, so I'm not going to emphasize it too hard here. But there's this concept called plasma oncotic pressure, and if you don't have proteins in your blood, the water will follow the proteins, and so you can have a decreased fluid because of this. Long story short, just this, you can have polycythemia because of the lack of liquid in your blood.
So is that number supposed to be 45, or is it?
Well, so it's like a range of like your blood will naturally. It's not always, your blood's not always perfectly 45. There's like a range, probably from like 35 to 55, just 45 being the average.
Okay.
It's not until you exceed 55 that it becomes a problem, or you get diagnosed with this condition, right? So if you're hitting 50, it's just like, okay, go drink some water and get out. You know what I'm saying? But if it starts getting 55, 60, 70, then you got problems, right? The second, which is just simply increasing the amount of red blood cells in the blood. You might have an excessive production of erythropoietin. People pronounce it different ways. So that might be because you are hypoxic, you're not getting proper amounts of oxygen, and so your body's overcorrecting for that negative feedback loop. And then you can also have cancer of your red blood cells, where you have a neoplasm of your progenitor cells in the bone marrow. And then that just gives an elevated amount of red blood cells as well. Make sense? All right, so that contrasts to anemia. A lot of us heard anemia. We briefly talked about it when we talked about sickle cell anemia and genetic disorders. And what this is where you have a severe decrease in the amount of red blood cells compared to normal levels. There are a few different causes of this as well. What this is going to lead to is decreased oxygenation, carrying capacity in the blood. This is why getting sickle cell anemia is bad, but all anemias are bad. Decreased circulating erythrocytes and decreased quantity of hemoglobin. All that should make pretty fundamental sense now that we know all this background, right? As far as what causes anemia, there's a whole bunch of reasons, ranging from genetic to dysfunctional hematopoiesis. You're just not developing red blood cells. You're destroying too many red blood cells. You're not taking the sufficient nutrition to develop your red blood cells, and or you just donated too much blood, or there's a couple different things, right? And I think we're going to be talking about 4 different types of anemia anyway. The signs and symptoms of anemia. So the first being pale skin, right? Just red blood cells actually give your skin some pigment. Blue skin, which is cyanosis. I guess there's some blue in biology for you. So you have, there's this whole song and dance with the color of oxygenated heme group of hemoglobin. If it's bound to carbon dioxide, it looks more blue, and if it's bound to oxygen, it looks more red. So that's why they call it cyanosis. That you have more blue blood than, which is just probably the lack of red, though. There's like a debate. It's dumb. I don't know. So red skin flushing, you have an increased. Yeah, so it's like, it's dumb. It's like colors, or I mean, this is just like going back to color coding your classes, huh? All right, but anyway, so there's different types of anemia, and we're going to be talking about. We've already talked pretty well about the sickle cell anemia, but we'll touch on it again. The first type of anemia is megaloblastic anemia, and this is where you have hold on. Okay, never mind. So this is where you have deficiencies in things like folic acid. So again, folic acid is really important for development, and that's why you take it when you're pregnant. For dividing cells, they need a lot of folic acid. Well, if you're not getting it, you need it even as like just a normal person, just to a lesser degree. You need it because you need to replace these red blood cells, right? And so if you don't have any folic acid, you're not going to have proper development. Also, B12 is another important developmental thing. So these with megaloblastic anemia, it's characterized by having these large oval shaped, like they're larger megaloblastic, right, big blast, which is like the precursor. It's like you just have a bigger cell type compared to like all the humans have normal, like a typical normal cell type size. So if it's bigger, you have these megaloblastic symptoms. It's also correlated with Helicobacter pylori infections, and older patients having gastric atrophy. And with gastric atrophy, right, is where you're not your digestive system is atrophying. It's like decreasing in its ability, so you're not absorbing those really important minerals that lead to red blood cell development. It's not necessarily your muscles. So we talk about muscle atrophy a lot as like the example, because it's like it's easy. Honestly, it's like you break your arm, you don't use it for a while, your muscle gets weaker, you have atrophy. But atrophy is any time that the organ or tissue gets weaker, and specifically weaker at its function. Yeah. So if you're a muscle cell, it's your little strength, your ability to apply force to an object, that decreases with atrophy. But if it's like, you can also have other types of atrophy, like gastrointestinal atrophy. It's a decreased ability to absorb nutrients, because that's what that tissue does, right? So it's anything, yeah. It's not necessarily muscles. Now it can be your muscles of like peristalsis through your like stuff like that. But good question. It's like a confusion that a lot of people have. So it also is a problem with alcoholism, right? With alcoholism, you have really bad gastrointestinal problems as well. We're going to talk about alcoholism a lot in this course, obviously, because that's a very physiologically damaging thing to do to your body. But also smoking as well.
So you don't drink at all?
No, I
like
drink.
Not even a beer?
No, I drink.
Oh, okay.
I'm not saying. I mean,
okay.
It would be better if I didn't, but like,
Yeah.
I like getting drunk sometimes. Like I'm a normal person. I mean, no, people who do like.
Yeah, excessively.
Well, no, people who like don't drink. It's like I respect those people because they're like considering their health a lot. But
well, I never really started drinking until I got to nursing school.
No. I started. Yeah, I never drank until I got to college, I guess. Anyway, so yeah, treatments, you want to just, I guess I glossed over the Helicobacter pylori stuff. Helicobacter pylori is a bacteria that infects your stomach. And so because your stomach's infected, you don't have as good as digestion. Y'all can think about it that way. So if you take antibiotics and get rid of that H. pylori, you can replace those. Like you can get rid of that bacteria, and then your nutrition will be restored as far as absorption. Also, B vitamin injection pills, nutritional counseling, making sure you're eating the proper nutrition. Yeah, that's how you get rid of this. There's also iron deficient anemia. You can see here, this is what people are referring to with like the colorist stuff. Normal amounts of iron in your blood, they're very red, but then they turn like more bluish purple if you don't have that proper amount of iron. So here's iron deficient anemia, where you have you just don't have adequate amounts of iron in your blood. Is effectively the root cause here. Now, what's causing that iron problems can be numerous. Neoplasia, inadequate iron intake. There's like vegetarians that can run into this stuff because they're not eating any meat, and there's a lot of really good iron in meat. But then also pregnancy, all the iron's getting shuttled to the baby instead of you as like the mother. And then chronic blood loss from GI ulcers. This is like where you're bleeding so much into your stomach, it's then digesting. You have a lot of blood loss. Your body's trying to replace that iron, but it's not being reabsorbed and deposited to the blood as well. And so the big thing, just to put a Band-Aid over the bullet hole, is to take iron supplements for all of these, but then also you want to attack whatever that root cause is, right? If you have cancer, you want to go attack that cancer too. Or if you're pregnant, you want to have a baby, I guess, So yeah. So there's some examples of iron deficient anemias. And so just make sure to look at that while you're studying. There's also dilutional anemia. So this is where it's reduced hematocrit due to increased volume of your plasma. This is where you have more volume, and so because of that, the ratio of red blood cells to liquid is decreased, right? And this can be because of rapid loss of blood cells. So if you go like donate too much blood, for example, you lose equal amounts of percentages of all things, right? Your liquid component and your blood component. The thing is that when you drink a glass of water, your body can absorb that water really, really quickly, right? It takes like the process of cell replication to replenish your blood cells, though, right? So what happens is that your body will replenish your volume a lot faster than it replenish your red blood cells. And so what you're doing is you're keeping the volume the same, but you have decreased amounts of red blood cells, and that's what your anemia is. And it's just diluting through and through your red blood cells. And this can happen after injury or blood donations or any severe amount of blood loss that can occur. Yeah, that's pretty much what's going on there. And then we talked extensively about sickle cell anemia. I don't think I'm going to repeat all of this, but this is just where you have this genetic problem, and then your cells are sickled. Your hemoglobin's not functioning. It's not getting to oxygenation, and then there's also an increased amount of destruction of the red blood cells, and then it's very painful. But we talked about this pretty extensively. Sickle cell anemia complications. You get these skin ulcers, hydroxyurea. Is a way that you can stimulate this. Again, I guess if we're going to get rid of drugs, you don't have to learn hydroxyurea, so don't worry about that one. Because this is something people typically take for that. But you can also get blood transfusions, red blood cell exchange, and bone marrow transplants to help treat. So thalassemia is another genetic disorder. Did we talk about this in genetic disorders? I can't remember. Whatever, we'll review it here. So what this is, it comes from sea blood, and what it was first described in Mediterranean people. That's where it gets its name from. But it's a mutation in either the alpha or the beta chain of hemoglobin. And you'll see next slide what we're going what I mean by that. But because you have these mutations, you have insufficient red blood cell production and hemolysis. And then symptoms can include just iron buildup. You have organ damage, gallstones, and blood loss and malformation of blood. So what happens is that with thalassemia, you can have mutations either the alpha or the beta chains. With the alpha chains, you have this really is only 1 to 4 defective genes, and so the more genes you have defective, the more impactful it is. And so if you just have 1 alpha gene that's affected, then it's decreased severity. But if you have 4, it's increased severity. It's a direct correlation there. So that's all alpha genes are non-functional, and it's fatal in utero. So these people don't even grow very well. With the beta chain thalassemia, you have defective genes in the beta chain synthesis. It could be a number of mutations, where you have a minor degree, you're missing just 1 gene, or you can have major gene where all beta genes are non-functional. Average life is about 17. So just make sure you tell the difference between alpha and beta chain mutations. As far as thalassemia treatment, you have blood transfusions, iron chelation. You remove excess iron from the blood, and vitamin D for bone loss. Let me just take a look. Yeah, so this will be the last slide on this. So with that's all I wanted to go over. Hemostasis. We're going to talk about hemostasis in another lecture later on, and so we'll just end it here.